Wow, good afternoon. So the title here is important, I think, because this gets more to our quality structure and the emphasis for us as a hospital and trying to where we're going, right? So where we're trying to go is to be the preeminent facility in the United States that takes evidence-based medicine and turns it into quality as fast as possible. The challenge with medical literature, and you all will see some of this, is that the average time to implementation, even at best hospitals in the United States, some at 7 years, some are quick enough to get to a year to 2 years. No one's more rapid than that. But if you think about it from a patient perspective, if something changes that should change your care and it's reported, it should change your care. Does that make sense? And so you as the patient, there's not a timeline. And the other reason that I didn't put our J or I's topic up here is because this is actually not our presentation. This is your presentation. You all were the ones who are part of the respiratory therapy group at a Pragmatic Critical Care Research Group site. So this is just presenting you back your data. That's all it is. This is not ours. This is not a research thing. This is literally yours as the respiratory therapy department and others about what the trials that you all were part of actually presented. So I think that's important. The other thing I'll tell you is the goal for us as a hospital here is to move into the top 50 in the United States in terms of overall hospitals, and how our framework is where we believe we're the best is to be the national leader in time-sensitive diseases and procedures. We already know we're at national best practice in ST elevation MI. We already know that we're a comprehensive stroke center. If you look at our stroke data, it's insane. We're really good from a stroke perspective. From sepsis, you all know we are now the national leader in early diagnostics. Our risk-adjusted mortality is in the top 5 in the United States right now for sepsis. For surgical airways, we all have collaborated to get together to create that novel approach to surgical airways called Code Airway. And we're beginning to review every single one of those events. And we've seen a significant reduction in emergent surgical airways since we started that. That's a collaborative to review and be more iterative. And if you think about that work, this is the work that follows that. In 2025, what will be our goals? It may be now. Number one is we will begin to standardize pulmonary embolus. We're going to enroll and start enrolling, been selected for something called pulmonary embolus track, which is a huge NIH trial looking at submassive PEs and what's going to be the standard of care. We will begin to look at that uniquely. Vascular emergencies, we're already really good at AAA, but the question is can we be better? And then lastly, what Jay will talk about at the end here is if you think about any disease entity where we can end someone's life, and I say that without reservation, intubation is it. There are only a few things where the patients are critically at risk, and they have put more trust in us than anything else. And that's transferring them when we're in charge of their airway and we're in charge of their blood pressure. And then when we make the decision to put them on a ventilator, yes, they may not survive if they don't go on one, but some of them may. And we are making the decision to take control of breathing. So it is as we teach everyone, if you don't respect the process of intubation, you probably should no longer intubate. And that's just it. If you're not at some point have some heightened awareness and anxiety. And so when we think about these, as you all know, we're also doing handoffs and transitions as a process. So that's the work that we're looking at. So we're very dedicated to this. You guys are critical to every piece of this. You've been aggressive and phenomenal partners in every part of this. And so all of these are your work, but I just want to make sure that we're all aware. The last part I'll put is, this is not new in terms of respiratory and critical care having things that are, quote, landmark, right? Landmark are trials that come out where someone says this should change practice, right? There are lots of trials that come out every day where we talk about research. There are three formats where landmarks could possibly go, right? One is the New England Journal of Medicine. The next is Lancet, which is Europe's version of the New England Journal, essentially. And the other is Journal of American Medical Association. Landmark randomized trials go in these three. And what I'm about to show you is pre-oxi, and pre-oxi went into the New England Journal, okay? So I'm gonna give you clinical background. Jay's gonna give you the trial part of it and the data, and then we'll kind of tag team back and forth, okay? So If you all need to do it, this is going to be part of the slides we hand out. This is the one pager that came from the New England Journal when it was released on June 13th. Okay. So just so you all know, your work is in the New England Journal. This is the one pager. This is obviously the preeminent article in the United States for medical literature. What is the Pragmatic Critical Care Research Group? So this is a clinical trial network. It's EDs and ICUs at 25 centers across the United States. It's multidisciplinary, right? So emergency department, anesthesiology, and critical care. Our lead on the critical care side is Dr. Walker for our institution. He actually sits on their national subgroup. And what this is looking at things we do every day and having the idea of, do we know the answer to this question, right? So let's take that back to the trial I showed you before, which was lung protective strategy ventilation, which you all know is just, quite frankly, the standard of care. The hypothesis behind lung protective strategy ventilation was about high oxygen levels and survival. The group that got high tidal volume ventilation actually had better PaO2 and better stats, but they died. And that's how we know that oxygenation is not the target for critical care patients, that the intervention is actually more important to be pressure and volume related. And that's how the goal became a stat of greater than 88, because the group that unfortunately died in that randomization, right, were patients who had better oxygen. And that's how that entire idea and concept changed, where oxygenation in that trial was not necessarily the goal. Right? What we learned in that trial, though, is that there are parameters where things become dangerous, right? And the parameters are severe hypoxemia, right? And severe hypoxemia is what we're going to talk about surrounding intubation here today. But I want you to look at the bottom, right? Because the bottom, I think, is important for everybody in the room. These are your cohorts now, right? This is the other respiratory therapy departments in the United States that are participating in here. And you can pick up who you want in there. There are some huge names, right? UAB's in there, Leahy's in there, Colorado's in there, Ohio State's in there, Denver Health is in there, Oregon Health Sciences is in there, Baylor, Scott, and White, right? So these current places are some of the top medical centers in the United States that are your partners and cohorts in terms of where you work, right? And so as we think about people that want to come work with us, one of the things we should be willing to say is, if you want to come and work and be part of this kind of environment, you in Baton Rouge, or quite frankly, in terms of Louisiana in general, you're coming to work with us. Because otherwise you're going to a place that's going to be great, but it's not going to be at the leading edge in terms of development of clinical trials and thinking about airway management differently. This is actually the background data that I think is really important for you all. This is shown, and we're giving you the actual slides that were presented at Critical Care Reviews, which is the international conference where all of the data was released here. Operating room intubations and ED and ICU intubations are very, very common. Having said that, they have dramatically different risks. And we know this because OR intubations, for the most part, can be canceled as part of the algorithm. And when you get to the ED and you get to the ICU, canceling the intubation is unfortunately not an option in the algorithm. When you assess the airway and you talk about how difficult it's going to be, there is not an opportunity to postpone the procedure coming because you're intubating because of a physiologic challenge. And so as a result, the high risk, or the risk of having a negative outcome, is markedly more present in ED and ICU. And what are the two outcomes that are really significant? Number one, hypoxemia, right? And it's actually the strongest risk factor for perioperative cardiac death or peri-intubation cardiac arrest and death. And so in our intubations, quite frankly, the literature reflects that it happens commonly and frequently, right? So every critical care provider and every ER provider in the United States understands that these airways are different than anesthesia, okay? The other is hypoxemia at its number associated, and does it actually in randomized trials end up with an outcome that's negative to the patient? Meaning, if it's similar to ARMA, where we're looking at 95 versus 88, and people are shoving for 95, is there an outcome to the patient? When we look at this kind of data, you ask the possibility is, does the hypoxemia relate to the cardiac arrest, and are they naturally true, and causal? And we'll show you data that yes, in fact, this was looked at, thought to be a concern, and it proved itself to be true. So you all know this whole group knows this, right? This is essentially pre-oxygenation. This is the background. Lots of people who aren't respiratory therapists were having to be explained about what the concept was. But when we separate essentially together pre-oxygenation, I want you to get with the minutes there, because the minutes become important in the trial design. So before induction of anesthesia and initiation of laryngoscopy, we begin to do a pre-oxygenation with 100%. And if you can look here, you'll see that as the resting oxygen consumption stays at about 250 mils, we have to give an amount of oxygen beforehand. This is interesting for us because this also assumes, in terms of where you are, that your patient doesn't have the worst VQ mismatch or something else. And so these data are essentially related to normal lungs, but you and all of us are intubating together patients who have severe VQ mismatch, patients who have some form of shunt, other reasons in emergency and ICU patients where the need or the ability to pre-oxygenate has always been a question, and the question of how you do it and for how long has been studied by Pragmatic for a while now. So what are the two most common themes? Two most common themes, and these are the goal of Pragmatic Critical Care Trials Group is to study things we do every day and to try to get an answer, right? No longer to assume that the way I do it is the right answer for the patient because I've done it for a very long time, but really to say, is there an opportunity of what is best practice, okay? If you think about this, this is also similar to other medical literature, like how we feed patients. We feed patients every day. Have we studied? Thankfully, we started in the early 2000s to look at how much, when, how long, because everyone was just doing something. Does that make sense? And so here's the way that probably most in the United States do pre-oxygenation. We put an oxygen mask on, then there's something that delivers 100% FiO2. At our concept in terms of risk, we say there's no risk of, quote, gastric insufflation and therefore aspiration. It's easy, it's quick. What it doesn't have is positive pressure ventilation. What it doesn't have is any ventilatory assistance going on, right? And what it also doesn't have is, depending on the mechanism that you're choosing and where you have your entrainment potential with room air, can be high or it can be low. Depends on the minute ventilation, depends on how the person's breathing. But remember, 100% is coming from the wall, it's in the bag. 21% is circling that whole thing. This is not a closed system, okay? And for this group, I'm gonna pivot here. Closed and open systems are super critical, right? Super critical. Closed systems get a mixture of oxygen and gas into a closed system. Non-invasive and invasive. BiPAP, invasive, okay? The only open system that we, quote unquote, do a mixture of is our heated high flows. It's the only one. You have to ask yourself why, and then you have to ask yourself, how much is your patient actually getting if you're in an open system breathing 30 times a minute through 21%? Does that make sense? So we're going to talk about that in terms of the next movement for us from a quality perspective after this, but it won't be this trial. But this is a really important concept because this concept plays in both the open systems and then the closed systems in terms of non-invasive. Here's the other way to pre-oxygenate. So we provide 100% FiO2 and positive pressure. It does provide ventilation when the patient goes apneic. Obviously, it's more difficult to set up theoretically. And there is this hypothesis risk of that the patients will aspirate more, that when you put them on BiPAP, they will aspirate more. Now, I think this is interesting post-COVID because everybody went on BiPAPs, right? And we didn't see, like, walking down the hall, every fourth person throw up on themselves. But when it comes to intubation, this still maintained itself despite 2 years post the pandemic, right? Everyone went on. We waited, we let them eat, we did all this stuff, and people weren't just like walking down the hall being like, whoa, oh, vomit in mine. That didn't happen, even though we were letting them eat. So just thinking about that, you just have to think about the things that we've traditionally been taught, right? And so this is pre-oxygenation with non-invasive. And then here were the current guidelines and evidence before this was started, right? And so it said to provide some pre-oxygenation with either non-invasive or an oxygen mask. Both were equivalent. And that oxygen mask used for pre-oxygenation is about 75% of the patients in the United States. I would tell you that it's probably all of the patients up to this point who just already weren't on non-invasives, okay? Now, I will also tell you this. This is also, if you think about this, is the reason that you see experienced evidence-based intubators never pull someone off a non-invasive to go to an open system, right? Everyone at best practice, even before Pragmatic, was staying on positive pressure and intubating from positive pressure. It was not positive pressure off and a mask on, right? Because you didn't have ventilation, you didn't have positive pressure. So if you've seen that practice by individuals, that's because that was best practice when you were on it, because you were coming to a different delivery mechanism, okay? So there have been 2 prior randomized trials, 53 patients with acute hypoxic respiratory failure in 2 ICUs in France, where non-invasive looked to decrease the risk of hypoxemia, and then another one where it didn't decrease. So the concept and hypothesis was created from guidelines and what apparently was. And so this is pre-oxi. So pre-oxi stands for, everybody's got to have their own little acronym, Pragmatic Trial Examining Oxygenation Prior to Intubation, right? You can't do a trial these days without it. And so with that, I'm going to move to Jay after I tell you what the hypothesis was. Here was the hypothesis. I gave you the entire background. The hypothesis was that pre-oxygenation with a non-invasive ventilation will reduce the incidence of hypoxemia compared to pre-oxygenation with an oxy mask. So it's literally randomizing 2 different strategies to see what the results are. So Jay, I'll let you go from here.
And like he said, the pragmatic group tries to answer simple questions. The way we answer the simple question isn't always that simple, but, again, we've been doing pre-oxygenation with a mask forever, and we didn't know if it was the right thing to do. So I think 24 out of the 25 centers, 17 of the 25 centers, it was just 24 enrolling centers, participated. One of the EDs and one of the ICUs were here. So thank y'all very much. This isn't a journal club, so we're not going to nitpick this too much, but it was parallel. It was blinded up until the point of randomization, obviously not blinded after that. And they were 1-to-1 randomizations, okay, in block format. Anybody who was an adult who needed to be intubated was a potential eligible patient. And then the obvious exclusion criteria, if they are pregnant or a prisoner, automatically excluded from just about every randomized trial, okay? If the need for intubation was so urgent you did not have time to randomize them, they were excluded, okay? If they were so obtunded they were already significantly hypopnic or apneic, those were excluded, okay? If for whatever reason the physician determined that one method or the other was absolutely necessary or absolutely contraindicated, those people were excluded. And then the vast majority of the exclusions were if you were already on positive pressure ventilation. As Dr. Thomas said, we don't take that away to then place an oxygen mask prior to intubation, okay? This was under a waiver of informed consent, as both of these intubation or pre-oxygenation strategies were considered standard of care. The IRB was okay with waiving consent. And then the patient's family was given some information about the trial after the fact, okay? Again, randomization was blinded or blinded until randomization, okay? All right, now the 2 strategies we kind of talked about briefly, but I'll go over them again. The positive pressure arm, the intervention arm, okay? This was done with either a Respironics device or a ventilator with the face mask mode, the non-invasive mode, okay? Needed an expiratory pressure of at least 5 centimeters, an inspiratory pressure of at least 10 centimeters. We gave them a backup rate of 10 at least, and then we tried to pre-oxygenate them for at least 3 minutes, okay? Once we hit the 3-minute threshold, then the patient's induction medicines were given. I mean, everything else is set up, right? And you only removed the mask when you were placing the laryngoscope in the mouth, okay? Then the control group, I should say, is the face mask group. And we simply left the face mask on them at least 15 liters per minute for at least 3 minutes. And we only moved the mask out of the way when the laryngoscope entered the mouth. Now, the other way you could do this was you could use an ambu bag cranked up to at least 15 liters held over the patient's mouth, but you could not bag because that would provide positive pressure and ventilation, right? And so I know that's totally against y'all's instincts. When you put that mask on there, you want a bag. And so y'all were all very good about not doing that, okay? All right, so the primary outcome, and these numbers are somewhat arbitrary, okay? But hypoxemia less than 85%, or a SAT of less than 85% defined hypoxemia. Now this looked at the entire time between the time induction of anesthesia medicines were pushed out to 2 minutes post-intubation. Okay, now that total time frame is going to be variable depending on how long it took the induction meds to hit, how long it actually took the patient to get intubated, and then as soon as the intubation happened, that 2 minute clock started. Okay, and so all this data was recorded at the bedside. Secondary outcome was simply the lowest SAT recorded during that same time frame. Okay. Now remember, Dr. Thomas mentioned with ARMA, higher saturations were associated with worse outcomes, but that was because we were doing stupid stuff with the ventilator and stressing the lungs past their breaking point to a certain degree. The secondary effect of that was an improved saturation. Okay, that's not to say that if you didn't get to an extreme level of desaturation, it wouldn't be harmful. Okay. Now, this was not powered to look at any of these outcomes. Okay, these were just exploratory and safety outcomes, but looking at different degrees of hypoxemia, different definitions of cardiovascular collapse, systolic less than 65, you needed to go on vasopressor, you arrested. Okay, and then the big one, though, is aspiration, okay? And they were really interested in looking at the number of aspiration events in each group, since this concern just lingers forever and ever and ever, okay? Actually enrolled 1,301 patients, okay? The sample size was estimated to be 1,300 if we assumed that 17% of the face mask patients were going to desaturate, and we wanted to look at a 6% difference, okay? It's an intention to treat, so it didn't matter if you actually were given the prescription that you were randomized to. If something got screwed up and it messed up, you still got put into that group, okay? All right, again, 1,301 patients were ultimately randomized out of nearly 5,000 screened, okay? So the major exclusions, again, were you were already on positive pressure ventilation, or it was so urgent that we didn't have time to randomize, okay? That's half of the exclusions, at least. If you are actively vomiting something, okay, then you are excluded, a little over 10%. And then I don't know exactly what defined this, and I can't find it in the supplement either, but a high risk of aspiration, okay? Not entirely sure what the enrolling clinician assumed meant high risk of aspiration that would have excluded a patient. But again, I mean, it's a handful of numbers.
What did you do? Did you have any of those?
No.
Okay.
I'm not entirely sure, unless they are actively vomiting something, food, blood, whatever, I'm not sure I would just look at them and go, maybe you're at a high,
Aspirated before.
I think this is.
maybe,
Maybe.
or like if they've been NPO from speech or something because they have horrible dysphagia,
This is,
stroke.
in randomized trial, this is the emotional weakness out. That's what this is. So in every trial that you start to design, there is a provider or a group when you're doing big randomization where you have to let the emotional response of the provider doesn't have equipoise means they think they absolutely know the answer to not enroll. And so in these, if the person is so convinced historically and has made their own assessment of who is high risk, you have to provide that for them. It's no different than, I'll tell you another trial, there's a trial called the Villanueva trial, which is about upper GI bleeding. So upper GI bleeding, and we randomize patients to 7 versus 10 is the hemoglobin, okay? And one of the exclusion is, quote, massive hemorrhage. It's not defined, can't be definable. Like this isn't definable. And in that trial, 1.3% of the patients were excluded by ED providers because they were, quote, massively hemorrhaging. If you went back and looked at those patients who were excluded, because the trial people did it, how they decided they were massively hemorrhaging is really difficult, right? Was it just the presence of blood at the bottom? Was it something else? Does that make sense? And so each trial now has to have one from a data monitoring safety board and from an IRB, because the IRB has to declare that it's safe to do these trials under these rules. And so what you'll see in almost every big, huge one is a movement from the IRB to be able to exclude patients who the person, if we're enrolling without consent, right? Because it's that the person who is going to do the procedure says, I don't think this is safe. And so that's what that is, if that makes sense. Very small amount, but this is in every big trial. I always call this the people that know better than the question being asked. And so we've all met them. So if you're interested in the answer, you're not one of the, if you think you know the answer ahead of time, you could be in the 38. If you're interested in the question and you go, I don't know the answer, then you don't end up being in the person who took the 38 out. Does that make sense to y'all? Right? That's the, I know already who's at risk. And we can talk about a really famous trial one time about lidocaine in the same exact answer, but I'll do that one afterwards.
Yeah, but I'm not entirely sure what I would throw there, because you already have the need for intubation, a high risk of death, and I've already decided maybe I can wait 3 minutes because I want to randomize them, but I'm not going to because of a perceived risk. Yeah, I'm still not entirely sure what that was. All right, anyway, fairly balanced 2 groups, okay? No big outliers from any of these baseline characteristics.
Okay, go back one second.
Okay. Yep.
Just for y'all.
Yep.
So think about this, right? Who are these most consistent in presentation? This is sepsis or septic shock, right?
Yeah.
Also look at altered mental status is very common. So a change from baseline is very common over half of the patients. And the other one I want y'all to look at is these patients are sick, right? A quarter of them are already on some kind of medication for shock, right? A quarter on vasopressor. So there are trials where you look at and someone goes, well, those patients aren't as sick as our patients. These patients are sick, right? The only other thing I'll tell you is they are also not our patient population. So just when Jay gives you the results in certain subgroups, look at the average BMI there. 27 and 26. That is not our facility. So just to let you know, our facility trends more towards 30 and above 30 than it does 27 and 26, okay? European trials trend in the low 20s. American trials go into above 25. For us, when we look at our BMIs in our sepsis trial, it's higher than that. Okay, so just recognize that we have a little bit more of a weight opportunity as it relates to the deep south than other locations, and that's important when Jay shows the results, because what we're going to be looking for is in that population, is it still true, yes or no? Okay, does that make sense?
Yeah, and we supply the upper end of that range in those groups, okay? But yeah, you are taking some super sick people and then giving them some drugs that is gonna take away what little drive of anything they have. So, like you said, if intubation doesn't give you a little anxiety, perhaps you should be doing something else. All right, so in the group that got randomized to oxygen mask, almost all of them actually got an oxygen mask, okay? And vice versa, of the people who got randomized to non-invasive ventilation, almost all of them got non-invasive ventilation. There was some crossover, okay? But that's the whole point of the intention to treat. Even though some of these folks got put in the wrong category, got the wrong intervention, we're going to assume that they actually got the intervention that they were assigned to. But this actually helps us out a little bit in the data set. All right. This is a busy slide, but I think the take home here is that, all right, before induction, all right, while we were pre-oxygenating them, SATs were about the same, okay? Now, during that pre-oxygenation, if you break it down, most of them had a saturation greater than 95%, and about the same number had a saturation less than 90%, even during the pre-oxygenation phase. You get all the way to the time of induction. In the oxygen mask group, you still have a significantly higher percentage of folks with saturations less than 90%, okay? Or 95%, excuse me. And more of your folks in the non-invasive group are picking their saturations up to higher than 95%. All right, so just from this, you can tell that there's already a split, okay? Blood pressure doesn't really change. Sedative neuromuscular blocker requirements don't change, okay? And then between the induction and laryngoscopy, there's not really a significant difference between supplemental oxygen use. Everybody's getting oxygen pretty much. But there is a big difference between positive pressure ventilation. Now, you'll see 31% here in the oxygen group got positive pressure ventilation, but that was actually okay by the trial design, even though the authors did not want it to happen. But you got your either your positive pressure or your face mask during the pre-oxygenation period. But once the RSI drugs were given and it was time to actually take a look and intubate, if you didn't get it and you had to oxygenate them again, you had to go take a break, you could actually, it was okay to go on positive pressure with an AMBU, okay? And then take a second look. So that's where most of those come from. All right, so what does it all mean? Well, if you break it down, and remember that less than 85% was the primary endpoint here, okay? 18.5% of patients in the oxygen mask group desaturated to less than 85% within that time period that went out to 2 minutes post-intubation, and only 9% of patients in the non-invasive ventilation. So basically a risk reduction of about 50%. And if you look at more severe degrees of hypoxemia, that 2 to 1 still kind of holds true, okay? Now those numbers are relatively small though, in the grand scheme of things. If you know, I always look at axes, and if you put that out to 100% and looked at it, you know, all those are going to be really small. But if you're the patient that desaturated and had a cardiac arrest, that's really the only thing that you care about as the patient, okay? So if we can decrease the incidence of hypoxemia, we may very well decrease the number of cardiac arrests we have peri-procedure, right? Now, it didn't matter if you did not have acute hypoxemic respiratory failure, okay? In the patients who didn't have, say you needed to be intubated for some other reason, still favored non-invasive. It was still better if you had a BMI less than 30, still favored. Of course, the bigger you get, the better the benefit, okay? And even if you didn't require oxygen at all and you were on room air in the hour previous, it still showed a benefit, okay? So even in the least sick of the sick folks that didn't have any obvious VQ issues, any acute issues, aren't very big, okay? It all mattered. And then, you know, we don't often use Apache 2s anymore, okay? But this is a nice separation between some that are super, super sick. The higher the Apache 2 score, the worse you are, okay? But even in the not so super sick patients, actually showed a pretty good benefit to go ahead and put them on non-invasive, okay? This is busy, but it's actually really easy to think about. This is BMI, okay? 30's in the middle. All right, so we're on this then, okay? Non-invasive, and this is hypoxemia, percentage of patients with hypoxemia, okay? The non-invasive group, that's pretty flat, okay? So it doesn't matter what your BMI is, we're actually able to manage your degree of hypoxemia relatively consistently across weight ranges. But with an oxygen mask, the higher the BMI, the higher the percentage of hypoxemia, okay? And then the graph on the right is simply one subtracted from the other, okay? So your absolute risk difference in hypoxemia actually gets much, much lower at higher BMIs if you use non-invasive ventilation versus if you just use face mask, if that makes sense, okay? The bigger you are, the more it favors non-invasive. All right, we can skip that one because that's not really all that helpful. Safety outcomes, remember, included aspiration. And there were over 600 patients in each arm, and the number of aspiration events was in single digits in each arm. Okay, so, anecdotally, we learned that, well, there's not that many aspiration events with non-invasive during COVID. Now, these numbers aren't quite the number of COVID, but again, now we've got measured data that show, yeah, okay, maybe aspiration is not nearly as bad as we think it is. And maybe that's not something we need to worry about moving forwards. There are always those patients that are going to have aspiration as a problem. But it did not seem to be an issue in this study, okay? New infiltrate on chest imaging was one of the secondary outcomes, and no difference there. New pneumothorax, equal between the two, very small number, okay? FiO2 at 24 hours, no difference. SAT at 24 hours, no different, okay? First pass success, no difference. Not really surprised though. This wasn't a different intubation strategy. This was a pre-oxygenation strategy, and everything after the pre-oxygenation was the same, okay? Cardiovascular collapse, no difference, okay? And that includes either a low systolic pressure or an increased or new need for vasopressor agents, okay? And then cardiac arrest, well, I'm not entirely sure there's a difference here. It doesn't cross zero, okay, in a confidence interval, but these numbers are really small. But interestingly, there are 7 events in the oxygen mask group, but only 1 event in the non-invasive group. If I'm not mistaken, that 1 event in the non-invasive group was actually here in the MSCC, but I can't remember which patient. And so this is going to be, I think, an exploratory, this was an exploratory outcome for maybe something in the future, but I don't know if that'll ever be done because hopefully, if this strategy kind of takes hold, we'll have fewer hypoxemic events and few periprocedural cardiac arrests, okay? So basically, we cut the incidence of hypoxemia, defined as a saturation less than 85%, in half. The number needed to treat here is 11. That's a nice number needed to treat, okay? So for every 11 patients we do this to, we potentially save a life, okay? We have 1 episode of cardiac arrest in the intervention group, and aspiration really doesn't seem to be an issue, okay? That's kind of what we just did there. All right, we already talked about the limitations with the excluded patients. There was back and forth when we were kind of finalizing the manuscript and then going back and forth with the reviewers about, we didn't evaluate high flow nasal cannula. No, we didn't. And so we still don't know where high flow would fit in with this strategy, okay? There is always the talk about, well, maybe at really high flow rates, it might provide some PEEP. And with the high flow rates, it would certainly be relatively effective at potentially washing out all the nitrogen, which a non-rebreather could potentially do the same thing. So we still don't know how high flow nasal cannula fits into all this. So I don't know that anybody is going to look at it from here on out, but we might at some point.
So from a quality perspective, we wanted to bring you this trial because if a provider or you all are at the bedside and they decide this is what they want to do, similar to video laryngoscope, like those are both now best practice, right? So Chantel's done a phenomenal job of trying to figure out how we operationalize this and how we use the ventilators to do it, right? Because if you're at the bedside now and you've read this trial that came out, and you want to pre-oxygenate your patient, providing best practice is this. Does that make sense? What is not best practice anymore, again, not standard of care, best practice. So this is an interesting question for us of, well, how do you apply rapid evidence-based medicine, right? And how do you apply evidence-based medicine in a way that both Jimmy, myself, and Jay and others, we can look about what our current state is and what post is. And that's what essentially quality is. And so Chantel's been looking, and we've been trying to build with a huge database that allows us to be automated. Right now it wasn't automated. So we've been working for 3 months to try to figure out what the experience of every intubated patient is, right? Because if you go back to that first of what the goals of the institution are, right, and what the goals of now our new CEO are, is to do this. It's to be the best at any time-sensitive disease and procedure, right? So we wanted to make sure that you guys were as up-to-date as humanly possible as any respiratory therapy group in the United States, and that you also understood that the suggestion box of, hey, I'm willing to do this may also be best practice, right? You guys have changed lots of things by suggestion. ET tube size in this institution is dramatically better than other institutions. You can ask Dr. McWhorter. We suggest obviously 7s because the literature says that. Can I mandate that? I cannot. But because we now have gone to a smaller tube size, the amount of laryngeal injuries is dramatically lower, right? We used to do 8.5 high-low vac tubes. We don't do those anymore. We do 7s. They're actually, Pragmatic is going to do a trial coming up that's going to be 7s versus 6s because they're convinced that our tube size is way too big even at 7, right?
Yeah, well, and there's a couple of centers in the PCCRG that are already using 6 and 6.5.
Yeah. Yeah, so the idea that we know the size and the things we can't do related to the size are all our practice habits. Does that make sense? Like, I've done this for a long time, so I think this is the answer. You just have to look nationally and think, well, someone's doing something completely different. Why are they doing it? Does that make sense? So we're gonna work with y'all to figure out what's the least in the workflow, what is the easiest way to get this done. I did a couple upstairs with some of y'all, and we used use the ventilator, turned it on, and we're using the mask, right? And then we have an elbow. So we're gonna look at what's the best for the patient and the easiest for the workflow. We are not gonna bring non-invasives everywhere around the hospital. We're not gonna do that. We're gonna use the ventilators. But we have to figure out what makes the most sense with you all as subject matter expertise so that when someone we know we're gonna be intubated, that our process to come into intubation includes the opportunity to apply pre-oxi, because quite frankly, the literature, and I guess up to date, says we should.
So we have looked at using the vent, as Dr. Thomas said, not in the non-invasive mode on the Drager vent, but in the invasive mode, you can actually use it like in a pressure mode, and then as soon as you intubate, you can switch them over to your regular settings of whatever you're going to be on. So we're going to have an SOP written so that it tells you what to select for that intubation. And I think Dr. Thomas did it with a couple patients, and it works well. Also, we can do it on the HT70. The HT70 as well has a mode that we can use, but we won't be using the V60s. We're not going to have a V60 in every room for intubation. And the data collection that they're talking about, the post-oxi, as you know, Our documentation, we now document for the intubation, the lowest sat, pre-oxi before the intubation. We document all these additional things. That's to collect the data that we can look at later as we move toward this best practice.